different clinical meetings regularly at different medical colleges by Asthma Association. Asthma Association Bangladesh holding orientation course regularly on updated asthma management for all doctors at all levels. The National Asthma Center is surely playing an important role towards elevation of the sufferings of millions of sufferers. The implementation of the second phase will be more beneficial for them. COPD situation in Bangladesh. COPD is the fourth leading cause of death worldwide. Globally, COPD by 2020 is expected to rise to the third position as a cause of death, and fifth position as the cause of loss of disability adjusted life years daily. National Institute of Disease of the Chest and Hospital, the COPD in IDCA scenario. In last year, 2009, COPD patient was 1,755, that is 44% of total admission, and other non-COPD patients are 3,369, that is 66%. Almost more than one-third patient were COPD. Admitted female COPD patient in medicine wards at NIDCA COPD, 81 patients are female. In 2009, that was 5% of total COPD patient, and the rest 95% COPD patient, that is 1,523, was male. Outcome of admitted COPD patients at NIDCA. Among the patients who got admitted themselves in NIDCA, 1,259 patient was discharged with discharge certificate with advice, and 188 patient are taken discharge on request, and 96% discharge on respond, and 12 patient was outstanding, and 139 patients was given in ambulatory support, 139 patients, and 141 patients expired. Our total prevalence among all ages is 4.32%, and above 40 years of age it is around 21.58%. Almost half of the patients suffer from moderate COPD, 45.13%. Male-female ratio of COPD patient is 1.6:1, but more female sufferers in rural areas. Sufferers are predominantly from lower economic group, 80% almost. More belongs to productive age group, that is in between 40 to 50 years. About 63% are smokers. 80% of smokers COPD patients smoke more than 10 pack years. Exposure to biomass gas in rural area is more than 80%. Tobacco, smoke, socio-economic conditions, environmental pollution, and solid fuel combustion are mainly responsible for the development of COPD. As per general clinical observation, the prognosis of COPD in Bangladesh is somewhat worse than that in the developed countries of Asia, as most of the people belong to low socio-economic status and incapable to avail the modern diagnostic and therapeutic options. So I have asthma, but asthma does not have me. Thank you very much.
Exercise capacity, we know, has gained importance in evaluation of various disease states. In this perspective, I have made the study of the 6-minute walk test in healthy volunteers and its comparison with COPD patients. Timed walk test evaluates functional exercise capacity, we know, and assess various disease states, and it reflects the capacity of daily activities. Other than timed walk tests, other exercise tests according to complexity are stair climbing, shuttle walk test, detection of exercise-induced asthma, cardiac stress test, safe use protocol, ETT. The 6-minute walk test has certain advantages. It is easy to administer, better tolerated, and more reflective of daily activities, and it requires no technical expertise or equipment. Spirometry is an indicator of respiratory function, but respiratory function is not the very close of measurement of functional capacity. So it alone is not useful for overall assessment of COPD. While FEV1 is the only marker of respiratory system, the 6-minute walk test evaluates overall systemic effects, that is the global and integrated response of other systems. The objective of my study was to measure 6-minute walk distance in healthy subjects and at the same time in COPD patients, and to compare the distance between the two. The another objective was to compare the 6-minute walk distance between stage 1 and stage 2 COPD patients, and to see the effect of 6-minute walk test on heart rate, respiratory rate, and oxygen saturation. Methodology. It was a prospective cross-sectional study. Initially 110 healthy subjects and 110 COPD patients was enrolled, and 5 COPD patients was excluded later on as they meet the exclusion criteria. The inclusion criteria for healthy subjects was age 40 to 70 years, both sex, male and female, no injury affecting the exercise capacity, and the ratio between FEV1 and FVC more than 70%. Inclusion criteria for COPD patients was that is FEV1 and FVC ratio less than 70% and FEV1 more than 50%, that is stage 1 and stage 2. We have followed the gold guideline in staging the COPD patients. The exclusion criteria of healthy subjects was locomotor disorder or any other disease that affect the exercise, and the person having bronchial asthma. The COPD patients who are clinically unstable, has sacral or ankle edema or reduced saturation less than 90% was excluded from the study. I simply need an indoor, flat, straight and unobstructed corridor with no distance, which was marked at regular interval. And the patient and the health volunteers was advised just to walk as far as possible for 6 minutes, to cover as much distance as possible, and he was allowed to stop to rest if needed. But the time was 6 minutes from the beginning. If the patient developed chest pain, intolerable dyspnea, leg cramp, staggering or excessive sweating, we ask the patient to stop walking. Results. The prime objective of this study was to measure the distance. The distance walked by the healthy subjects and the COPD patients within a period of 6 minutes. In my study, the total distance walked by healthy subjects was 564 meters, and by the COPD patients 339 meters, which was the difference was statistically significant. The stage 1 COPD patients walked 375 meters in 6 minutes, and the stage 2 COPD patients walked 300 meters within 6 minutes. The heart rate increased both in volunteers and patients, the pre and post test heart rate, and both was statistically significant. The respiratory rate also increased from pre-test value, pre-walk value in both in volunteers and patients, and both were statistically significant.